and I'm glad to see everyone. Good morning, Dean Reynolds. So we have a lot of material to cover, and I just want you to keep that in mind, and we have many recommendations to review. So we would like to finish today, but keep in mind, if we are not able to, we will have to schedule another meeting in September. So just please keep that in mind. Dean Reynolds.
Good morning. Thank you.
Okay, so let's get started with announcements. I know Dr. Doring has some announcements he'd like to share with us.
Yes, thank you, Dr. Hughes, and good morning to everyone. I know it looks like I'm in the desert Southwest, but I'm actually here from Glens Falls, New York today. We, this past weekend, concluded our Chesapeake Dental Conference, where we had 500 to 600 dental professionals attending at Maryland Live. It was a great conference. I do want to highlight just a couple things from that conference. On Saturday, we had a CE panel discussion, giving back to your community by participating in Maryland Healthy Smiles. The moderator was Dr. Hughes. Dr. Romaine and I were participants, as well as Ms. Sandra Kick from the Department of Health. I thought we probably could have used a couple more hours of discussion. It was a very enlightening course and a lot of participation. I also want to thank the Department of Health and Skygen for having a booth at the meeting, and I understand we did recruit some providers, and there was a lot of literature passed out about the Maryland Healthy Smiles. The next thing I wanted to mention was I'm glad to announce that the MSDA House of Delegates on Sunday passed the following resolution, 2022-09, and I will read it. The resolution, be it resolved that the Maryland State Dental Association support, promote, and advocate for the establishment of a dental home for all children by the age of 1. Be it further resolved that the Maryland State Dental Association will, 1, explore various mechanisms to require documentation of a dental home as an admission requirement to daycare. 2, educate and collaborate with government agencies, health departments, professional organizations, and advocacy groups to advance this policy of the Maryland State Dental Association. And 3, communicate our position to legislators. So we're really, I think that goes well with what we're doing, especially in the pediatric, what we've been discussing. The last thing I want to just mention, in August issue of JADA was a very good article called Impact of Disability Diagnosis on Dental Care Use of Adults in the United States. It was actually authored by 2 faculty members, Dr. Chavez and Dr. Masick, at our dental school here at University of Maryland. And I just want to read the conclusion of that. Adults with intellectual, acquired, or developmental disabilities have decreased access to oral health compared to adults with other disabilities or without disabilities. The ability to afford oral health lessens the impact on ability status. So that's a good article to review and be helpful to the task force. So thank you.
Thank you, Dr. Doring, for those updates. Does anyone else have anything they'd like to announce? Okay, if not, let's get started. I hope everyone received the report. I know you did not have a lot of time to review, but we appreciate you taking the time. So Lindsay is sharing our screen, and what we will do is go through each section, and any member that has a question or has an edit they would like for consideration, please just raise your hand. So let's start. We're here in the introduction. Does anyone have any comment?
Can I interject something really quick?
Certainly.
I just wanted to let folks know, and also for the benefit of anyone who's watching us on YouTube, we do have a couple of members who couldn't make it today. I invited anyone who couldn't make it. Obviously, they have the ability to send a proxy. Neither of them have proxies here, but I invited them to send comments to me via email. I haven't heard anything from anyone. So I just wanted to let everyone know that those members who couldn't make it did have the opportunity to contribute, and I was going to share their thoughts, but I didn't hear anything from them. So I just wanted to let everyone know that.
Great, thank you for that. Yes, Dr. Dorn.
Thank you. Just on the background on page, it might be helpful because sometimes printers don't print these out in order to put the page number, but I believe it's page 3 of this document where it talks about dental radiation technologists.
Oh, no, we want to go in order. Is that okay?
Yeah, it's in the background.
Oh, so we were on the introduction. I was asking if anyone had any comments so we can move forward to the background. Okay.
Thank you, Dr. Hughes.
Certainly.
On that page 3 where it talks about the paragraph, a dental radiation technologist, on the very last line, I think we can eliminate, it says to place or expose of dental radiographs. I think we can eliminate the of or reword that in a different way.
Okay, can you?
It's
because
the very last.
Okay, under dental assistance?
Yeah, the top of the page has a bullet point chapters 106 and 111 of 2016.
I think I'm right here on the screen. Does that look right?
Yes, please. That's correct. Thank you.
Okay, thank you. Thank you for that catch. And just real quick, while can everyone see this size of the document all right on their screen? Okay.
Okay, and so your recommendation was to remove this sentence?
Remove the word of. It was just an
just of? Oh,
word.
okay.
Yeah. I have a feeling that we changed the wording of that sentence and just missed removing that word.
Okay.
And I'm using track changes here just to let everyone know. My goal is going to be to try and type in your thoughts. It might not be exactly the way it will be worded. You know, if we're putting in thoughts quickly, in this case, this is pretty straightforward, but later on when we get to some of the bigger items, I'll be typing them in so that you can see everything, but we might adjust the wording just a little bit for the final draft, which of course will circulate before the next meeting.
Okay, Dr. Romaine, you have an edit for the background?
Yes, I believe this is on page 5, I think. Again, it's hard to say. It's where it's talking about the EFTAs, chapter 364 of 2022. So I think it would be before that actually. Would be up, right? Right, there you go. So okay. I think here it would be a good idea because this, who's the public reading this? I mean, it's the state delegates, for them to just know that we are waiting, as Dr. Verma told us, promulgation of regulations from the board on this. Like, it's not actually happening yet. As of October 1st, 2022, we're waiting them their regulation. So perhaps that'll be different come December, but I think that's important to know. Maybe that would be better put up where you're introducing the chapter 364 of 2022, where it's talking about waiting the EFTA credential from the board to perform, and we are waiting board. Thank you.
Yeah, we'll put in a line about that and the anticipated timing of those.
Okay, are there any other suggestions for this section?
I have another suggestion. I think it's on page 6.
We've got the salary range at the top.
Yeah, I think I'm getting my pages mixed up. It's where we start to list the states for dental therapists. Or we aren't quite there yet. Okay. Perfect.
Okay. What's your suggestion?
So again, looking at the fact that our public here are state legislators, I think it's important if you go to the area here in the first paragraph under dental therapists, where they say dental therapists are intended and they list out the duties in other states. Doing surgical extractions, extracting teeth, doing surgeries is one of the things allowed in other states. So I do think we need to be specific with the legislators to let them know how dental therapists are used in other states. You say non-surgical periodontal therapy and other, but I think it's important that they know that.
So what would you like to list here specifically? Surgical extraction?
Yes, and dental extractions.
I'm sorry, what's the exact wording that you'd like? Surgical extraction and
other services.
okay, and other services.
And
And
like
might
that?
add irreversible procedures.
Irreversible procedures?
Irreversible procedures such as surgical extractions and other services.
Dr. Romaine, it's Hawk and Clement. I think maybe even just putting restorative work too,
Yes.
like fillings, you know, because other services, yeah, like you said, the legislators aren't going to know what that is. So they would do fillings.
So we've got restorative work, irreversible procedures, surgical extractions, and other services.
How about put irreversible procedures such as restorative work and surgical extractions and other
That sounds
services?
Ricardo Kembers here. Do we really want dental therapists to be doing surgical extractions?
No, we're just giving background and that's being done.
But they're being done in other states?
Yes.
Well,
So,
I hope that I never go to any of those states to have a surgical extraction done. I want to go to a dentist, not a dental therapist. If they want to practice dentistry, go to dental school. That's
So
how I
what-
feel about dental therapists, but that's just a sidelight.
what we can add at the end of this sentence is these services vary from state to state, or something to that effect, to let them know that these are not services that are rendered in every state, but these are just the potential procedures that they can practice.
Dr. Hughes?
Yes.
Go ahead, Dr. Romaine.
No, I was going to say, it's my understanding that these are the services that are rendered by dental therapists where they exist on tribal lands and in the 2 states that they practice. There are 131 in Minnesota and 1 practicing presently in the state of Maine. So that was going to be my next comment, is I feel like in the next paragraph where we lift out the states, it's great the way Tyler and Lindsay, you guys have listed where this has been, as you said, which practice was authorized. In other words, the state legislators have approved this. But I think it's important for the legislators to know, though approved in these states, where the therapists actually exist. And so the current data that we have from the ADA as of yesterday is that in the state of Maine, there is 1 dental therapist currently practicing. In the state of Minnesota, there are 131. And in the tribal territories of the state of Oregon, there are 15. I think too, in addition, it would be a good idea to put where the dental therapy schools are. Currently, there are 3 in the country. And I mean, you know, this is a lot of stuff. I could email this to you too. There's only 1 approved dental therapy school, and that is in Alaska. And there are 2 in that is called Iskavik College in Alaska, 1 CODA. And then there are two others, University of Minnesota Metro State and Minnesota State in Mankato, Mankata.
Mankato, it ends with an O.
Thank you, thank you. Yeah, so I think that kind of data is important for them to know and to understand. Thank you.
So Diane, are you going to email that to Lindsay to?
Happy to, happy to.
Yeah.
And Dr. Hughes, I was just going to interject. If you look at, I think we want to be careful to provide example of services provided, but the Commission on Dental Accreditation states very clearly that the competency is in simple extraction of erupted primary teeth.
Mhm.
States have the prerogative to modify that, but I want to be careful that we don't imply or suggest that in fact the scope of services are significantly broader than what the Commission on Dental Accreditation provides in terms of guidance.
Can we scroll back up, please, Lindsay, to that portion where we talk about what services are provided? Yes, right there. So, Dean Reynolds, are you suggesting that we not be specific and take these out?
I think to provide an example, but I would not depart far from CODA's guidance documents. And the other is that it's with supervision at a level specified by the State Dental Practice Act. So, and I think we have flexibility here, but surgical extractions, I think probably is outside of the standards that code or guidance provided by the commission. And I'm hesitant to put that in specifically.
So that Diane, you have a suggestion?
Yeah, perhaps we could just get the CODA standards and write them in there. So to Dean Reynolds' point, which is a good one, that we have the exact thing of what's accredited. I think that might be a good idea.
Yeah, and I have them up actually. I can forward them to you, Lindsay.
Great.
Thank you.
So
I just have one more.
okay.
I have one more thing if I may. Under the list of states, there's a line that says, in these states, dental therapists work. And to me, under where you have the list of states, it makes it sound like I said, besides correcting where there are numbers of dental therapists, it makes it sound like they're working in all the states. So I think that specific line needs to be edited, where it says, in these states, dental therapists work. I think we need to make it clear. I see how you have it. Okay.
I was going to say, what I did is I added this line about dental therapists are only actively practicing in Minnesota, Maine, and the tribal territories of Oregon. And then, so now it's in those states, dental therapists work primarily in settings, serve low income.
And Alaska, shouldn't Alaska be in there? Tribal territories of Alaska?
Are they in Alaska?
Yes.
Okay.
Mary, you have a comment?
Yes, thank you, Dr. Hughes. I want to just go back to the excellent point that Dr. Romaine brought up in terms of listing the number of therapists in Maine, Minnesota, and Oregon. And I wonder why just those three states? Why not list the number of therapists that are in all the states that are bulleted?
Yes, Diane.
It's because, Mary, they aren't practicing in all the states. And I think what is confusing in the count is tribal lands aren't considered a state, right? So in Alaska, they're practicing in tribal lands. So that we'd have to get, but there are no current practicing dental therapists in Vermont, in New Mexico, in Nevada, in Montana, in Michigan practicing. The state legislature has said, yes, we're open to having a curriculum, but it hasn't gone through yet. They haven't produced any dental therapists yet. So that is why.
Terrific. Thank you, Dr. Moroni.
So that statement, that they're only practicing in those certain states needs to be highlighted, because if you look at this list, that's the first thing you think, that there are therapists practicing in all of these states. So I think that that needs to be a point that needs to be highlighted.
Dr. Romaine, can I ask for the source for the list that you gave about where they're practicing?
Yes, the source is the American Dental Association, Matt Rosato, who is in charge of keeping current records. And I was in touch with him yesterday. So I'm happy to give you his email so you could get it directly from him.
Thank you. I just want to make sure that we're not excluding. So like Washington has it's listed in tribal settings, but there aren't any in the tribal lands in Washington.
He did not have that in the current listing that he gave to me yesterday. But again,
I just don't want to
we need ask
inadvertently
him-
leave anyone out.
Totally. We need to ask him exactly. I'll set up that email right now.
Thank you.
But he's very thorough because there's currently only one in the state of Maine. So if there's one, it's included.
Okay, great discussion. Can we move forward? Are there any other suggestions or edits for the background section?
Well, I think this gets to an important question that, so Tyler and I noted throughout the document, you'll see discussion notes. And I think probably the most prominent for discussion today is that there's the background information on dental therapists. This was one of the items that the enacting legislation specifically asked the task force to look at, but none of the subgroups actually had a recommendation related to dental therapy. So I think the group needs to decide. We can certainly end this discussion in the background section on dental therapy saying that the group has not come to a conclusion and is not interested in making a recommendation related to dental therapy. Alternatively, you could say that the group, has looked at dental therapists, but didn't feel that there was enough information to make a recommendation. And you could recommend that a work group be convened to study the issue further, to look at dental therapy, the potential for dental therapy in Maryland.
Dr. Romaine?
Thank you, Dr. Hughes. Whenever I look at page 1 or 2, at where you're listing out what we're supposed to be doing, it's the task is assess options to eliminate such barriers, including the feasibility of establishing a program for dental therapy in the state. But I do think if we're assessing the options, this might be a great place to put in community health workers in Maryland and their impact there. I don't see that that's been included in the report at all. I know that the state of Maryland has, I think 15 community health worker programs across the state. We heard Dr. Jane Grover's presentation specifically about community dental health workers. But for example, whenever I investigated the state curriculum, there's no dental module in the state community health worker program. Well, that might be a great recommendation. So I would move that we provide the information on some of the barrier methods. Community health workers, dental therapists is an option. We also have the option of our expanded function dental assistants that we'll get to in a little bit, and how they are going to be providing dental sealants, which I don't know if you remember from our Minnesota colleagues when they spoke, they said was the #1 procedure that dental therapists did in the state. So I think we need to kind of in this section provide the options fully.
Thank you, Dr. Romaine. Actually, we have discussed this previously. There is a recommendation that does refer to a community health worker, and we feel like there should be further discussion. So later on in the recommendations, we would like to enhance what our recommendation is and discuss what it should look like for community health workers or dental community workers, however we want to define it. So we will have a discussion on that. Dr. Corman?
Thanks. I feel like it is part of our reason for being here was to talk about, the genesis of this oral health task force was due to the legislation a few years ago for dental therapists. And I think, this was created out of that. So I do feel like, instead of just giving options, I think we probably should make a recommendation on what this task force believes as far as dental therapists goes. So we're not just kind of pushing this down further and further. It seems like we should say, like, we either do or do not think that this would help in the state of Maryland.
So do you have objection to what was suggested, that we make the recommendation that there be further study, or that we don't feel like that is something that we could recommend now? Would you consider that we look at it further? Because I don't think we have enough information to say what the design in the state of Maryland should look like.
Yeah, I just think it's just one of these things that, we keep kind of discussing it, sort of. I just feel like, if the idea of this task force is that, look, there's a lot of different avenues that we can go to help with barriers of care, and dental therapy is not something that I think we need to introduce. We don't need to create another mid-level provider for this. That, we can expand on what we have, because I think a lot of our discussion is how do we get providers into those areas? And I think we should say, for me, I'm speaking personally, I'm not speaking for the board, but for me personally, it would be, I don't think dental therapy is the solution, but these other modalities of getting providers to these other areas, like expanding the LARP and expanding, expanded function dental assistants, and all these things that we talked about in our presentations, are the direction that this task force is saying that we should go. But I feel like we probably need to make some sort of recommendation on dental therapy, so that way this is either something that we are recommending or not recommending at this time.
I'd like to hear Dr. Romain, your thoughts.
So I would maybe kind of turn what Dr. Koyman said into a type of maybe motion to the group, to say that I would move to the group that at this point, we do not move forward a dental therapy program in the state of Maryland, that rather we focus on things like promulgating the regulations for the expanded function dental assistant, and for expanding community dental health workers, community health workers across the state, and some of these other barriers at this time. That would be my motion.
Dr. Doran?
Yeah, I like the way Lindsay worded the first way, and I agree with Dr. Koyman and Dr. Romain that we shouldn't kick the can down the street. We have other ways. In the testimony we heard from the pediatric dentist, I don't forget which date that was, but he stated it didn't work. When we heard the presentations from Minnesota, it seemed to me, when we looked at the graph, and I've got some data from the ADA, most of the dental therapists in Minnesota are in the Minneapolis-St. Paul area. They're really not in rural areas. So I don't see it helping us. And I think we should put our emphasis more on the CDHCs and the expanded function dental assistants that we passed this year.
Thank you for your comment. Could I get a concrete statement from one of you all that we can decide upon as a recommendation, please? Anyone like to offer that statement that we
Can
recommend?
Lindsay read what she read? She gave a couple of options, the first one.
So the first option that I suggested would be to say that the work group studied the issue but did not reach a conclusion relating to making a recommendation on dental therapists. The second suggestion that I made is that the task force could recommend that a work group be convened to study the licensure of dental therapists in Maryland. And that you could specify that work group study the required training and appropriate scope of practice for dental therapists.
I prefer the first.
To make other details, you can specify who should be in that work group and who should lead it.
It appears that from the discussion that the first option is what we should
And
consider.
if I could add that emphasis should be put towards the CDHCs and the EFTAs and moving those programs along. But after all this consideration, that's where we'd like to focus.
So Lindsay, can you add to the first thought to include CDHCs and EFTAs to see what that would, could you write that so we could see what that looks like?
So I guess, is there a recommendation specific to focusing on those, or would you like me to say something to the effect of has looked at the options for mid-level providers and recommends that Maryland further pursue use of community health workers and I'm sorry, I forget what EFTA stands for off the top of my head, and the use of the EFTAs for
expanded function dental assistance.
Yeah, to meet the needs of oral health access in Maryland.
Is Dr. Romaine?
Yeah, so I would say currently at this time, the Maryland Oral Health Task Force does not recommend the establishment of a program for dental therapy in the state of Maryland. We recommend pursuing increase in community health workers and in expanded function dental assistant duties at this time, something like that. But I would be clear, as long as the group would agree and move that's my motion, that we not support the establishment of a program for dental therapy in the state of Maryland at this time. I think that needs to be the first line so it's clear.
Okay, Dr. Corman.
I would agree with Dr. Romaine. I think, saying it this way, that we've heard testimony on mid-level providers and, the task, if this is the goal of the task force, that, we wouldn't recommend using it. And I would almost say, it would be community health workers, expanded function dental assistants, but also other modalities that are going to be listed in this report. I mean, so it's not just those two things. I think there's lots of ideas out of this report and how we get providers to certain areas. So I just think at this point, like if we're talking here and we're talking about dental therapists, I think that we've evaluated it and we don't feel that that's something at this point that we can recommend. And then I think we just continue with the rest of the document here and show all the different ways that we will be removing barriers to care.
Mary.
Thank you, Dr. Hughes, and thank you everybody for this discussion. I'm incredibly encouraged with regards to the focus on workforce in this regard. And I'm just not too sure if I'm comfortable with a motion that eliminates consideration of dental therapists when it really hasn't been fully vetted and discussed, really. We've had a presentation on it, but we really haven't looked at it in depth, as well as the other positions that are being offered here. And that's why I was very encouraged and in agreement with Lindsay's second option to have a work group study these additional positions in depth, in greater detail, with stats, and then look at it in totality at all of them before making a recommendation to just strike one down automatically. So I just worry about that. And there are comments in the chat as well.
Dr. Corman.
He's on mute.
Oh,
there we go.
Sorry, thank you. I respect that. I just think, by doing that, and creating another work group, we're just basically kicking this down the road again. I mean, I think, we have to make, I think we just need to make a decision if this is the right thing to do or not the right thing for us to do. And I think, it just, we've spent the better part of a year, going through this, and we've had presentations on this. I mean, I think trying to dig deeper down, I mean, it's just, I think it's just one of those things we need to decide on and then just move forward from there is my feeling. And I think is what I felt like this task force was sort of charged to do.
Mary? Is your hand up?
I'm sorry I forgot to bring my hand down. Thank you.
Oh, okay, thank you. Dr. Romaine?
Thank you. No, I believe that current information known at the highest level is before us. I think maybe if people need more clarification, maybe an idea would be to provide everybody on the task force with all the information so they know. But I don't believe that another group convening could gather more information than we have. Do you understand? Like, it's the current state. Maybe we need to spend more time on making sure everybody in the task force has it and feels comfortable with the recommendation. Maybe we could delay voting on this until a next meeting. But I do think people are depending on us to make the recommendation, and we are the ones in the know. And I think we could have the courage to learn, take a vote and move forward or not, depending on the will of the group. Thank you.
Okay, so we've heard everyone's thoughts, and we know that this is a topic, we can go either way, but we need to come to a consensus today. So, do other members have any thoughts before we move forward? Because I would like to move that we accept this recommendation and move forward. So if we have no further discussion, I think this will be the recommendation that we move forward for the report. Okay, so.
May I ask a clarifying question?
Yeah.
Dr. Koyman brought up that, so what we have here is sort of two pieces. The first is that the task force does not recommend pursuing the use of dental therapists at this time, or the licensing, we'll say, of dental therapists, but recommends expanding the use of community health workers and expanded function dental assistants. Dr. Koyman brought up that perhaps we remove that second clause because we get into more detailed discussion on those two areas a little bit later. So I could take this out and just have a period at the end of the clause about dental therapists.
Is that agreeable?
That was my suggestion, but that's fine to eliminate as long as we bring it back later on.
Yeah,
Okay.
because both of those are discussed with the more specific recommendations that are broken up by subgroup later in the report. Okay, thank you. I just wanted to clarify that.
Thank you all for that conversation, and we can come to some agreement. All right. Any other comments before we get to our subgroup recommendation? If not, let's start with our pediatric group.
Okay,
Is
so
there
there's
any-
just some more background on sort of how the groups were tasked with their work. And some background information that came from the pediatric group.
Dr. Doring? Dr.
Thank you,
Doring?
Dr. Hughes. I did want to go back just briefly to the loan repayment assistance in Maryland section. It's a great program. There's some recommendations coming up, and maybe to include the promotion of this program is done through the Maryland State Board of Dental Examiners. I don't think it's promoted enough. As a matter of fact, when we did our panel discussion last Saturday, we had a dentist sign up. He knew nothing about this, and he'd been practicing for 10 years, still has college loans, tuition and he would qualify for the waiver. So I think there's got to be better ways of promoting that. And I think that we need to consider that.
Well, I think that's a discussion we can have with the Office of Oral Health.
Yes.
Yes. Okay. Dr. Coleman, you have a comment?
to the pediatric side of things. I just
Okay.
wanted to confirm, under the Medicaid reimbursement rates, that chart for anesthesia by state. I just want to confirm, are these the medical rates or are these the dental rates? Because, you know, they do cover anesthesia per 15 minutes in office. But I think it's more important to also, because we got to tie in the medical side of things, because that's what's allowing us no access in ORs and hospitals.
I would have to look into that. I don't know offhand.
Okay.
Dr. Corman, your hand is up again. No? Okay. Okay. So any other comments regarding the narrative before we get to the recommendations?
All right, so I'm just going to scroll through all of this unless someone stops me. Stopping myself here. So the first discussion, or rather the second discussion note after the one that we already discussed on dental therapy, was related to one of the recommendations made by the pediatric subgroup, was on incentives for providers to be trained in a second language. But there wasn't really any specific barrier raised in the prior discussion relating to language barriers. So we just wanted to sort of tie those together to provide context for that recommendation if the subgroup felt that there was a specific language barrier that needed to be addressed.
Dr. Doring?
Yes, thank you, Dr. Hughes. Just a couple of questions on the pediatric section, maybe just before the recommendations. There was a bullet point that says childcare policies may not allow a parent to return to work after a dental appointment. I was confused. I've never heard of that problem. Is that a situation where parents cannot come back to work after they've taken their child to the dentist?
No, I think in that population, sometimes if you pull a child out of daycare, they can't return back to the daycare facility.
Okay, so maybe that needs to be reworded. It was unclear to me. So
Yeah, I think that's as related to if you can't bring your child back to daycare, then in turn you can't return to work. So,
okay.
So we'll say childcare policies that
Not allow a child
to not be returned to daycare once leaving.
that may not allow parents.
May
Yeah.
prevent a parent from returning to work.
Thank you. That
Right.
clarifies it much better. And then if I could, Dr. Hughes, if we go to on the recommendations, and this is a recurring theme when we
Can you hold that thought one moment,
sure.
please?
Mhm.
Okay. So we're clear with this statement? Yes?
Can we
Everyone?
change daycare to childcare? I think the correct term for that is childcare, and daycare is more of a. Thank you.
Thank you.
Okay, then, and if I could, just to keep us in order, because above this, before the recommendations, is this question that I raised about the language barriers. I just wanted to clarify again, if there's a specific feeling that there was a language barrier issue to tie into the recommendation.
Sorry, I don't mean to jump in front of you, Dr. Doring. Just speaking from the pediatric group, I don't know that we made that recommendation. I don't know. We didn't have anything as far as incentives to be to have providers be trained in another language.
Oh, we had this offer incentive/programs for providers and their staff to be trained in a second language.
It's number 3.
Yeah, I saw, I just don't remember that being a recommendation, but I mean,
We can take that out and then there's no need to have a follow-up. I think there was a similar recommendation from one of the other subgroups as well.
yeah, I think there was crossover on that.
So would
Okay.
you like to remove this one?
I think we can take it out here, and especially if it shows up elsewhere.
Okay.
We'll appropriately renumber to reflect that. I'm just deleting it for now.
Dr. Dorn?
That addressed my concern. And when we do revisit that, there are language translation services that the ADA / MSDA provides through computers. And just want to remind everyone that, and that also includes American Sign Language. And through the Americans with Disabilities Act, and also the Obamacare, costs related to translation services are bared by the provider, and not to the expense of the patient. So that's something we can revisit later.
Dr. Romaine?
Thank you. On point 2, we learned from our colleagues at Maryland Medicaid that Medicaid does in every county in Maryland have transportation services available. So I think we need to make note of that, or make our report inform that situation. Maybe we could ask Claire Serio or the people on the staff there what the resource is for that, but I think it does exist. Many of us just don't know that it exists for Medicaid patients to have transportation.
And this is Nancy, that is correct, that does exist. And we are in fact in the process of making some changes to our non-emergency transportation program to try and improve it. And we're switching from a model we're in the middle of a multi-year process to switch models from relying on local health departments to more of a broker models that would be statewide. So that's number 2 is something that we already are working on, or not specifically transportation vouchers, but we are making changes to our transportation program.
So maybe this, if we want to keep this, maybe we should include for those families that are uninsured, because that is a population that still has this issue of transportation. I see, Christy, you have your hand raised.
Yeah, I just would be opposed to completely taking out the transportation because it is an issue. And I know that Medicaid provides transportation, but it's really difficult to navigate, especially for people with disabilities. Accessible transportation can be hard to come by on a need basis. Sometimes there's shared transportation. So I do think it's something that we should not remove from recommendations. And I applaud Medicaid's action to fix that system, but I still think that there's work to be done there.
So should we put a note that for that population, there are barriers that still exist? Would you like that included?
So I don't know about pediatrics. I know, I would imagine though, that for pediatrics, there are barriers to transportation related, to similar barriers that people with disabilities have.
Okay, but we do need to note that the Medicaid system does provide that, but there's still barriers that exist for certain populations. Okay, so there are 17 recommendations. Are there any other comments about any of the recommendations? I know that we have to have a discussion. Number 5.
Yeah, number 5 had a comment about changing the WIC program, which is federal. So we had suggested maybe this should be advocating for changes to the federal WIC program, and whether or not that, what would that look like? Who does it?
Yes, Dr. Corman.
Yeah, I agree. I mean, I think the WIC situation is a federal program, and that's a difficult thing to change at our level. So I don't know if you just take it out as a recommendation or just say, something to, try to discuss with the federal program for the
Kristen.
future. But
Yes.
So don't all local health departments have somebody who is who facilitates the WIC program? And if so, then perhaps the recommendation could be more about providing those staff with information about the importance of oral health care, or, I think we've talked about creating informational flyers or things to distribute through the local health departments. Maybe that's how we can incorporate that WIC recommendation. I don't know if that was, if that's helpful, but.
So WIC does have an oral health component. So I don't know that it's something that we should really include, because unless we have specifics other than what they're already doing, I'm not sure that would be helpful. Mary?
Dr. Hughes, I agree with you, because we are working with WIC in terms of distributing flyers, just as Christy, is suggesting. So they do have a program, a nutrition specialist statewide in Maryland. So I agree with what you're recommending.
Okay. So can we can we agree to delete this? Thank you. Okay, number 6. Increase the number of dental assisting and dental hygiene programs to increase the supply of oral health support staff. Is there Dr. Romaine?
I think it's not only increasing the programs, but increasing the class size. I know in Allegheny County, our class size was halved from 40 dental hygienists to 20. And now 3 years later, we're seeing the effects of that. So I think the capacity through the class size is an important thing to put in there as well.
But why was the class size reduced?
I think it has something to do with just the number of chairs and their accreditation. I'm not really sure, I asked a lot about that and I didn't feel like I really got a straight answer. But from an access to care point of view, now we're starting to see the impact of 20 less hygiene graduates per year.
So is that a budgeting issue within the school?
I don't know, but I think we should mention that or unearth that or make it known that we want to watch the capacity of the classes too, that, we're putting through auxiliaries in proper amounts to the need.
Okay.
Dr. Hughes, if I may just offer
Certainly.
a comment. I think if you're going to make the recommendation to increase number, it has to be made within the context of that schools, normally the cost of the education is the barrier, meaning to increase class size and to fulfill accreditation standards, particularly with dental hygiene, requires that you have attendings. And so it becomes circular, meaning if facilities are constrained, who bears the cost of building out the facility? And the schools may not have the capacity, particularly community colleges. Second, then, is the cost of faculty. So I think the increased number of programs is an initiative, certainly to point to capacity. I don't know how you do that if there's no basis to support it financially. Schools will ultimately be constrained by those resource issues.
Dr. Corman.
I think my feeling is we're just making a recommendation here for legislators to read. And, I feel like once they have this information, then maybe they can, figure out a way to appropriate funds or, approve new programs or things like that. We're just kind of giving the recommendation, not necessarily that, there has to be concrete action on it. So I would just my feeling is I would just leave it to know that this is an issue that we as dental providers are having in the dental community. It's a barrier, and this is one of our recommendations. How we do it in the specifics, it's something that I think, yes, if we're talking about creating some sort of committee or something to, figure out how to do that, I think is the next step from there.
Dr. Corman, I agree with you. From my perspective, I would increase funding to support. In the absence of funding, you I think that's really, to your point, I agree with you. It's an important recommendation, but funding will make it happen or enable it to be possible.
Yeah, so I like the way it says increase funding to dental.
Yeah, I think that's a better recommendation. Dr. Doring?
Thank you. You hit the nail on the head, Dr. Reynolds and Dr. Koyman. The whole healthcare industry is facing shortages. It's not just dental, it's in nursing care, even physicians. The Maryland Hospital Association just came out with a detailed report on workforce. 1 of every 4 positions in hospitals is vacant right now. So definitely the state legislature is going to have to look at funding for all healthcare. So thank you.
Great, thank you for that discussion. Number 7, are there specifics other than the current legislation that expands the function for hygienists and assistants that you'd like to include?
Specifically, if you have particular scope of practice that you'd suggest be added.
But if I could, I would probably delete 7 because right now we're developing regulations on the EFTAs. And so I think that would take a lot of care unless someone has some other specific functions they want done. Right now we're in the midst of doing the expanded function dental assistants. And then we'll know more once those regulations are put into effect.
Dr. Romaine?
Well, I think even a few years back, as I understand, there was legislation passed to allow dental hygienists to do some limited prescribing. And again, that too is awaiting regulation and it's delayed. So maybe alluding to that regulatory kind of cooperation that we need, that maybe our legislators could help us with. I think that should be included in that section. And then, yeah, maybe this is a bit redundant to put the expanded function dental assistant thing here too, because we described it earlier.
Okay, thank you. Number 8, increase collaboration between medical and dental practitioners. Dr. Doring?
I'm sorry, but this is a real serious issue. And with this kind of goes with the MSDA resolution I raised in opening remarks. I've been kind of asking parents of young infants, what is their pediatrician saying? And I'm getting 2 totally different answers. Number 1 is, oh, see your dentist at age 1. We're not going to deal with that at all. The other extreme is, oh, we're going to apply fluoride varnish and you don't need to see the dentist until age 2 or 3 or 4. And dentistry is key to watching the development of children in developing speaking, feeding, many growth disorders. So I think it's key that we sit down with our medical colleagues and have this discussion and come up with some guidelines. Thank you.
Dr. Koyman?
Yeah, thank you. I agree with Dr. Doring. I mean, I think this is a task that, either, it just needs to be something that I think we as the dental community somehow have to get together with some of these pediatric residencies or with pediatricians and do some sort of talks, and whether that's facilitated by, the dental school or through private practice or MSDA. I just recently did a lecture for pediatric residents for physicians. And, I mean, the information that they got from that was something that they'll apply going forward. And they had tons of questions. I think it's just a matter of how we do it. So I don't know what we feel, if this is just something that we need. Again, if it's just information that somehow this needs to be done, and then maybe this is a charge, I don't want to put it on MSDA. I mean, but somehow Maryland Pediatric Dental Association. I mean, but I think somehow we have to get some way to communicate with each other.
So
So
if
I'm not, so I'm sorry, I don't have a direct answer of like how we do that.
Well, so if I'm hearing you correctly, I don't think that this is a recommendation that we need to send to the legislatures. That's something that we need to do with our professional organizations. Is that correct?
Yeah, I would agree with the passage of the resolution this past Sunday. The Maryland State Dental Association, our president, Dr. Booker, has already reached out to parties of interest to start this collaboration. I think it's going to have to come from state dental organizations with medical organizations and other healthcare practitioners to straighten this out.
Just to let you know, you can leave a recommendation in that won't have any legislative mandate in it. If you want to, and I've spelled organization wrong, if you want to just highlight that the task force has recognized that this is an issue. So you could have something like this: dental advocacy organizations should prioritize increasing collaboration between medical and dental practice. Just you're raising it that it's an issue, but it's not requiring a legislative solution.
Thank you. Can we move on to number 9? So, is there any discussion about this? Oh, I'm sorry, Nancy.
Yeah, I just wanted to raise about all of these Medicaid recommendations. There are a lot, just generally in the report, and a lot of these would require some significant budget initiatives, as well as, that would require us getting approval from the Department of Budget and Management. So it's not as simple as just being able to recommend it and having us be able to implement it. It would require a lot of work. And while we're happy to continue working with all of you about trying to implement some of these initiatives, there are a lot that are on the list. And a lot of them would be potentially have large fiscal impacts.
Dr. Romaine?
Just to point out, there's a typo on line 5, sodium diamine fluoride instead of silver diamine fluoride.
Oh, thank you. Whoops.
Okay, noting that we, Dr. Corman.
Yeah, I think, I mean, for me, I just feel like, we didn't really talk about sliding scale of reimbursement for underserved areas in our presentation. I think it's just, really significantly, and this has come up in, I feel like, every other section, which I think you have in the part that says, all the things that are coming out that we all kind of agree on. But I mean, I think, significantly increasing reimbursement rates. And I think that's like the biggest thing. I mean, I'm just saying, I don't know where we came up with the sliding scale, because I know that was not in our presentation.
Okay.
It might have been a verbal comment rather than we included both verbal comments that people made as well as the written presentations.
And sliding scale fees are available at local health departments and FQHCs, where a large number of the underserved are treated. So maybe that.
Did we just take this out?
Yeah.
Yeah, because this is in our fee-for-service programs, we don't have any sort of geographic difference between one region or another for paying rates. And I don't, we'd have to take it back to our systems folks to see if that was even possible. I don't know if it is. I don't think it would be.
And I guess I was just gonna say, like, and this is gonna come up later too when we're talking about the adult program, but instead of like concentrating on like specific dental codes like silver diamine fluoride and stuff, I think, I think just getting a greater financial pool of money, and then I think at the level of Office of Oral Health and things like that, we can talk about expanding coverages with, I mean the biggest thing is we need to have the finances to do it. like what's been being said. So instead of, maybe like talking about specific codes and specific procedures, more just talking about that there just needs to be more money diverted to the program.
Okay, and let's move forward to number 10. I think that this is, could be incorporated with number 11, with having dental exams required. That would increase the awareness of the importance of a dental visit by age 1. Are there any thoughts? Yes. Dr. Corman? Yes? No?
No,
I think he's
agree
just
with
doing
you.
a thumbs up.
Like,
I agree
Oh, okay. I didn't.
I
Okay.
agree with.
Okay.
So the comment on the discussion note on recommendation 11 is relating to sort of how does the exam, how is that mandated? Is that school-based oral health screening? We have the recommendation from MSDA relating to childcare requirements for dental screening. So how does this get mandated, essentially?
the mandates for the grade school kids is by county. And I did a study 4 years ago and looked only about half of the counties in Maryland require a dental exam at these certain age groups. So I think getting it.
This would be a statewide.
Yeah.
Statewide, yes.
And that would be a huge fiscal impact for the Medicaid program to implement something like that, since we are paying for a lot of the health insurance needs for our pediatric population.
Actually, it should say dental screenings. And so that wouldn't be any fiscal impact.
Do they have to be school-based? Can they come to a private office, have a form filled out and return it back to school?
I would recommend that it not be school-based, that they could, would be seen at any provider.
Okay.
And I think, of course, further discussion needs to be had on the ages and of course how it would occur. But just to make this initial recommendation, I think is good. Okay.
But the idea is that this is a requirement to enter childcare or public school.
Yes.
So even if it's not happening in the school, that's how it's being enforced.
Yes. Just like medical exams. Yes, Christy.
Just curious if the screenings would be available in school or childcare. And I'm just thinking back to the conversation that we just had about transportation. And we know that that's a barrier. So I want to make sure that we're not creating further barriers by implementing some, mandating something new.
Some
Well, I
counties are doing them in school-based, such as the Eastern Shore and Anne Arundel County currently.
It just depends on the facility. Any other discussion on that? So number 12.
Oh, one more thing. Should it be public schools or I know in Montgomery County, I fill out forms for those in private schools as well.
Well, I think that would require further discussion.
Would you like me to leave that out?
Can the
we
state
just say
require
school?
some? Yeah, I don't know that the
Say
state
school.
can require something for a private school. Can
Right. I think it's generally private schools tend to follow state requirements, but they don't always.
In the District of Columbia, just for note, it is required for public and private schools. But, okay, number 12. So as the Office of Oral Health provides this program, this statement is not completely accurate, in that when the provider takes the course, they are provided I'll call it a startup kit, which certainly includes educational materials for parents and also provides information for parents to gives them a link to SkyGen, which allows them to look for a dentist for their patients, and the office can also do that. So if I actually think that if I'll open it for discussion, but I think that this should be deleted. Yes, Dr. Quinn.
I agree with you. I mean, I think the wording on this is a little bit harsh. I don't think it's totally worthless. And I think this goes back to the section that we talked about already with improving in number 8, increasing collaboration with dentists and the medical field. And I think this is something that kind of ties into that. And I think, we could delete 12.
Okay, great. Thank you for that. Dr. Doran?
It's my understanding that if a pediatrician is to be reimbursed, they must take a course on the application of fluoride varnish.
Yes.
And that is discussed in the background section.
Thank you.
Great, thank you. Okay.
Now, I noticed there's not actually a discussion note on the next one, but
Yeah.
I will note to everyone that there's a suggestion or a recommendation here to increase the reimbursement rate on loan repayment assistance. But if you would all like to suggest a higher amount, we could do that, or else we could leave it open-ended.
Well, also because this program is run through the Office of Oral Health, and I see the applications, and there are providers that have significant student debt, and $25,000 is really just a drop in the bucket. If I had to recommend an amount, I would at least double it to $50,000 per year.
I would agree.
You could recommend that be reevaluated periodically as well.
Certainly. Okay, 14. Establish a grant or no interest loan program for providers to open practices in underserved areas.
So our note here was who should run this, and this suggestion on the Maryland Community Health Resources Commission came from Tyler and I, without having spoken to them. It was just an idea of an organization that already does something similar, but if you'd like to specifically suggest that someone take this on.
And I don't know that is everyone familiar with the Maryland Community Health Resources Commission and what they do? And does anyone have any questions about that?
Can you explain what they do?
Lindsay?
I wish Mark Lockhart were here. Let me see if I can pull up their website and get a quick mission statement or something from them.
While
Let's see,
Lindsay's looking,
their website says that they were created to expand access to healthcare services in underserved communities in Maryland. They're an independent commission operating within the Department of Health. It says since its inception, the CHRC has awarded 665 grants totaling $119.1 million, supporting programs in every jurisdiction of the state. So they award grants to expand access in underserved areas and supporting public health priorities. They staff some commissions. Essentially, though, they provide health grants in rural communities usually.
And we work with the commission, and who they fund and what type of programs they fund, it changes annually. So this would be something that could be presented to them to see if that would be an option for them. But it does seem like a good organization to establish something like this.
And this can just be a suggestion that they be approached about it or something. It doesn't have, obviously this wouldn't necessarily specifically task the organization we're taking this on.
Okay. 15, oh, okay, I'll let you finish that thought.
Okay.
You done there?
Yep.
Yep, great. 15, I think has, would be addressed in the requirement for dental screening. So I think if you all agree that we could delete this. Any objections? Okay, thank you. This form currently requires you to list the child's dentist. Any comment on this?
So just to provide some context, I think this was a comment that came from Dr. Doring during one of our meetings. So just, it was after the meeting that we looked up the specifics on the form, and we just wanted to clarify what should be updated there, what the recommendation should be specifically.
So if the going back to the required screenings, if that is something that would be implemented, that should address this issue as well. Dr. Doring?
Yeah, I'm looking at part 1 health assessment for school age kids, and I don't see anything related to, I'm just quickly rescanning about dental care. I see a lot of health information.
So
maybe I'm missing something, but.
So to clarify, we want a checkbox of oral health on their medical form.
Correct. And I don't see one existing now.
So let me ask you, if the school screening would be to be implemented, would you still want that?
I think it's important. It'd be like a double check. The parent or guardian is just checking it off. And I think it reinforces the importance of having that dental exam. A parent may realize filling out the form, oh, we forgot to visit the dentist.
So could we reword this to say that we would like verification of oral health care on the required medical school history? What is the exact term for the form?
It is.
It's called the health inventory.
Yeah.
It is called, okay.
Yeah, health inventory. I want to see last revised in 2016 is the one I'm looking at.
So Christy,
So here's the form.
Yes.
Does everyone see this okay? So this part right here that the parent or guardian fills out says, lists your dental care provider and then the last time your child was seen for a dental care.
Okay.
And then further
So it is in
down,
there.
then this is to be completed by a physician or nurse practitioner. There's just a check off on dental health right here.
Oh, so it's
Everyone
already
sees this.
exists.
But
Okay.
it would be checked off by your physician rather than by the dentist.
I don't have an issue with this form.
Okay. I bypassed it, didn't see that. I was looking more at the check marks.
Okay, so that going back, we can delete that.
You can delete it. Thank you.
Thank you. Okay, we've made it through.
All right, one subgroup.
Hey, okay. On to this is the
Why
adult
this is so
population.
dull. Yeah, I'm not sure why that's in bold. Oh my goodness. Sorry, I'm not sure why all of this is in bold. I think there might be a formatting issue here. I'm not sure if this is what it looked like when everybody else got it.
Yeah, that was, at least for me, it did.
Oh, strange. Okay.
Oh, it not on my hard copy, but okay. Is there any comments or concerns about the narrative of the adult subgroup? Or can we move to the recommendations? I don't hear any comments. Oops. Okay. Expand services covered for Medicaid for adults. I think we have that.
The specific services?
Well, I think that dentures and, okay, Dr. Doran.
Yes, and I know we've worked within state budget constraints, but we'll talk about the reimbursement under Medicaid. But there's also been suggested to me through MSDA leadership and members that we look at other avenues of recognition for those that provide Medicaid services, such as maybe some kind of tax incentive for seeing Medicaid patients. Maybe it's some kind of certificate that could be presented that, you know, it's good for providers to show our patients that we are actively trying to solve the access to care issues. So some kind of certificate.
I'm sorry, I don't mean to interrupt you, but does that address one of these recommendations?
Well, I think there's somewhere where it comes into increasing workforce as far as number of providers, but I can do it later.
Yeah, if we could just stay in order.
Okay.
Okay, thank you, I appreciate it. Dr. Corman?
Yeah, I was just gonna say, again, I mean, going back to what we said in the pediatric population too, I don't think we should get into specific services. I think the overwhelming thing is that we just need to increase funding to Medicaid. And then I think once we get the funding, then when we have money to do things, then we as sort of task force can decide where that money goes in the Office of Oral Health, as opposed to making legislation, because I don't want to like pigeonhole them and say like, okay, well, these three things, and then it's like, okay, well, we're going to approve to expand those. But then 2 years later, we come up with, you know, something else that needs to be done. I just think if overwhelmingly the idea is that we just need to increase Medicaid reimbursement rates
And we all
funding
know,
to Medicaid.
and we do know, I think we'll be able to come to a consensus later on what services need to be expanded. So we can keep this sentence as is, expand services covered by Medicaid for adults without further explanation. Is that agreeable? Okay, number 2.
Great.
Oh, I can't see number 2. Increase Medicaid reimbursement rates. Okay. Are there any comments on any of the increased funding?
And I'll just note also, we didn't say this at the beginning, all these asterisks are repeat recommendations that ended up being made by multiple subgroups. So the asterisks are there to indicate that these might be what you would consider high priority recommendations, because they're recommendations that impacted multiple populations identified by the task force.
Dr. Romain, you have a comment?
I was just looking at on number 3, like, do we need to say cover cosmetic function? Like cosmetic is kind of a uncovered service. I think if you just scratch cover cosmetic, you could just say denture services to cover functional needs for optimal oral health.
Thank you.
And Dr. Hughes, I was going to say, I mean, number 3 again goes back with number 1. I mean, we're talking about expanding services covered by Medicaid for adults, which this would fall under. So I feel like, again, we could probably just keep it with number 1.
My only reason to keep it would be that we know that this is such a missing factor in the upcoming benefit. I don't think that it would hurt to keep this specifically. Any comments?
I have a question on the removal of the word cosmetic. And I think you all will know a lot better than I do. I think sometimes there are, folks have missing teeth and it's not a functional problem in their ability to feed themselves, for instance, but it is and perhaps an aesthetic issue that could become a problem for trying to get a job or social issues. And I know that that was something that was specifically brought up by the members of the adult group. So I just wanted to raise that as far as removing the word cosmetic. Does that impact the nature of that recommendation?
Lindsay, if I may just interject, I was going to offer the same point, but reframe it from a mental health perspective. We talk about self-esteem, we talk about employment or employability. So I think the one is self-esteem, mental health. The second is their ability to be employed. And then, so I would consider that also in addition to functional needs.
And Nancy?
Yeah, and just to add, Medicaid normally doesn't really cover any cosmetic sort of surgeries. So if just bear that in mind when you're writing this recommendation, that that's not something we normally cover for our Medicaid population.
Dr. Romaine?
So how about if we just include what Dr. Reynolds said about for mental health? I mean, certainly Medicaid supports mental health and employability. Maybe we could just be very specific about those other two advantages.
I think you could just say I think you leave it as is and just say for functional needs for optimal oral and mental health, right?
Delegate Bagnall?
I was just going to say, could we say something along the lines of oral and overall health rather than carving out mental health? We have challenges with carve outs as it is.
Did you hear her, Lindsay? I'm having a little difficulty.
Yeah, there's a little bit of feedback.
I apologize. Is this any better?
Yeah, I think so.
I was just saying, what about something along the lines of oral and overall health, so that we're not carving out mental health, which is already a challenge with Medicaid reimbursement, but just tying oral health with overall health, so that we're not defining somatic versus mental health.
Great, thank you for that suggestion. That's helpful. So as Lindsay stated, the recommendations, they have an asterisk in front of them. They seem to have, they are come up in other subgroups. So if we don't have any other comments on those, we can move forward to the next subgroup.
Dr. Hughes?
Yes.
If I may just ask the question, I agree with Delegate Bagnall. On number 3, though, I don't know again, the question related to employment and the success of individuals in their efforts to become employed. Is that something that's germane here? Is that a benefit of the service?
I would think so.
So I see that as a different. So I think health is clearly, I agree. I might ask that we consider speaking to employment potential, because I know that that's critical also for overall well-being.
Dr. Romaine?
How about if you said for optimal oral, comma, overall health, comma, and employability?
I have no objection.
I'm going to leave oral and overall because they both reference the word health. So oral health and employability.
Great, thank you. Okay, so we can move forward to our next subgroup if no one else has any comments there. So the elderly. Any discussion regarding, yeah, Dr. Romaine?
So I think the text is well written. I have some things on the recommendations whenever you're ready to take those on.
We're ready.
Okay, so I would say recommendation 1, I think is good as is written. Recommendation 2, perhaps consider improve training for long-term care staff and caregivers on how to provide customized oral health for those who cannot provide adequate self-care. An example of the program that's recommended by the Association of State and Territorial Dental Directors is called Oral Health for Caregivers. It's an online program, and I know it's currently used at a lot of long-term care facilities and skilled nursing facilities. So that would be what I would say. Not that we're developing a program, it exists, but educating.
So who is going to take that on? Is it the long-term care facility that should be improving the training of their staff people? Is it something that happens during education before employment?
I would think Dr. Doring has a lot of experience in that area. Perhaps he could shed some light on that.
Dr. Doring, you're muted.
You're muted.
There we go. Each long-term care facility in the state of Maryland is required to at least have a dentist on staff or available when needed for dental care for their residents. And so I would think it would be the administrators of the long-term care facility, along with the dentist, to provide this training. And as Dr. Romaine said, there's some great online training, very easily accessible. Particularly comes to mind University of North Carolina, Mouth Care Without a Battle. It's a series of tutorials on how to perform oral care for nursing home staff or caregivers. It could be someone at home as well, to improve the oral home care of that particular patient.
So in that case, it's not a facility that would be providing the training.
Typically what I do is I go into the facility and their staff is required continuing education, just like dentists and dental hygienists, and provide an hour or two of said training. So it could be done solely within the long-term care facility using online services, or a dentist from the community going in and providing that training.
Do you all want to go far enough to say that this should be a legislative mandate, or is this just a suggestion for these facilities that it would be beneficial for them to do so without a requirement?
I guess it's always hard to mandate something. This goes hand in hand with what we were discussing with the dentists and physicians communicating. So those that are directors, medical directors of long-term care facilities, we need to have improved communication with them as well. So I wouldn't go for a particular legislative mandate, but maybe a recommendation that these training programs be enhanced, make sure they're included and enhanced.
And then also on this note is there a specific background information that you'd like to include relating to this recommendation? The recommendation's being made, but there's not necessarily a specific issue that was raised that it's addressing.
I would have to do some research and get back to you maybe at our next meeting on that. Find some resources.
Okay. I just want to make sure that we're providing context for all the recommendations that are being made. And we don't want to leave anything hanging as to why it's a recommendation.
Okay, so for number 3, the question is, would this be expand the continuing education? Are there not enough courses available? What's the response? Dr. Remain, you addressing number 3 or number 2?
No, I would say both. Like on 2, perhaps in the addendum, we could put some links to the North Carolina training program and the Washington training program, just as reference points. So those links are accessible. That would be my idea there. We could provide you with those links, Lindsay.
Okay.
No, I know that MSDA did a lot of CE with pediatric care, and I think MSDA could do more CE with care for the elderly and the medically complex patients with special needs here. So I would say, as far as perhaps Dr. Reynolds could speak to how that curriculum is at University of Maryland, but I think organized dentistry could do more to educate as well.
Dr. Dorn?
Dr. Yelowitz did give a course on this topic at the Chesapeake Dental Conference. I won't say it's not glamorous like implants and cosmetic dentistry, but it was attended. I think as far as training of dental students, I do an externship with the University of Maryland School of Dentistry, and all externships have really been canceled because of COVID-19. My hope is we can get back to that in the very near future, because to have students rotate through long-term care facilities, to go on rounds with physicians, to do a tutorial to nurses' aides, really is helpful, not just to the facility, but to as part of their education as dental students. So I think it's both ways. It's once you have your degree, it's got to be part of your continuing education component, and also part of your undergraduate degree.
Okay. So
you'd like to say that both in-school training and continuing education focus on exposure?
Absolutely. Absolutely.
Yeah. If I just may interject, our curriculum by standards includes training. Enrichment, as Dr. Doran points out, is certainly part of that.
But in both of these instances, it sounds like there's not going to be any sort of specific mandate. This is just a general recommendation that this is a good idea.
Correct.
yes.
Okay.
Number 4, we've already discussed. So do we leave it here? Or?
This is a little bit different than the loan repayment assistance. This is, or it could be, depending on how you all decide to pursue it. So you've discussed loan repayment assistance, but this would be tuition reduction and waiver programs, but could be on the front end from the school. I'm not sure exactly what the intention was with this recommendation, or perhaps it's just loan repayment assistance and then it is already addressed.
Okay, Dr. Remain.
So I would consider it already addressed in the LARP program. So I think that we need this again. And then just would offer suggestions for 5 and 6.
Okay, 5 and 6, what are your suggestions?
So I think 5 and 6 should be combined. Number 5, I would suggest improve resources to educate seniors on available dental benefits, such as Medicaid, those offered on the Maryland Healthcare Exchange, and in Medicare Part C. And
I'm sorry, can you repeat where you were again? Sure. I have improved resources to educate, except I can't read.
Seniors on available dental benefits in Medicaid or through Medicaid, on the Maryland Healthcare Exchange, and in Medicare Part C. And you know, now that part of the senior group was talking about how Medicare Part C isn't available regionally across all counties in Maryland. So perhaps here we could make a recommendation to look into the expansion of Medicare Part C dental benefits across more counties, because I know in my county they're available very, very few. And I think 6 could then be scratched.
Well, or is 6 the explore expanding Medicare Part C?
Yeah, availability, a Medicare Part C dental benefit availability in all Maryland counties.
Does anyone have any comments regarding 5 and 6 and the edits made? Dr. Corman?
Thank you, Dr. Hughes. I don't have any edits on 5 and 6. I think that looks good. I wanted to go back to number 4 though, because I think number 4 and going back to the pediatric group, sort of establishing a grant or non-interest loan program. I mean, I think both these were kind of meant in the same way. So I do think like the LARP is kind of after, but I think if we can capture, you know, if there's some way that we can do tuition reduction or waiver programs, you know, I think this was a good idea. I think expanding LARP to 50,000 is a good idea, but I mean, I think we like need to really like think about how, you know, this is kind of like a bigger goal, like to, you know, do some sort of tuition reduction and things like that. So I would actually like to see that back in, if that's all right.
Any discussion on that? I think, I don't know, we talked about the grant programs that could potentially be administered through the commission. Would that satisfy this? Tuition reduction, I don't know, that is, I think.
Yeah, it would have to be like a scholarship type thing. Maybe
Yeah.
that could come from that group preemptively. I don't know.
Right, so Dr. Doran, thoughts?
Oh, I wasn't going on this issue. I was going back to Dr. Romaine and the Medicaid inclusion.
Oh, okay. Well, can we complete this one first?
Yes, please.
Anyone's thoughts? Do you think that suggestion for the grants, would that suffice for this? Or do you specifically want this kept?
I mean, I think tuition reduction is like a big thing. And if the state can somehow find funds to create some tuition reduction in exchange for, you know, dentists to go to underserved areas, I mean, I think that would be a huge thing, you know, because you can get the LARP, you know, you could live in an area that's not underserved or practice in an area that's not underserved and still receive the LARP.
Well, no,
this
we
would be
really focus,
like
we focus
preemptively
on those.
like pushing dental students to go to areas that are underserved through
No,
a
we
tuition
focus
reduction
on the
program.
underserved area. Because we look at where we have mappings that show where dentists currently practice, and we tend to want to fund areas that aren't. So that does address that somewhat, but I need to know, do you want this left? Yes?
Well, Dr. Hughes, if I may just ask, is the question related to tuition reduction? Dr. Koyman, is that the item 4?
Yes, that's what we're talking about.
All right, I would my inclination would be to frame it similar to other programs to attract more dentists to underserved areas by providing tuition relief or reimbursement.
Well, so I guess these are sort of two different approaches. One is a tuition reduction or waiver for someone from the beginning when they're in school. It might be a little bit harder to manage because it's with the promise that they will then work in an underserved area.
Right.
The loan repayment assistance is you already owe that money, and in exchange for going to an underserved area, you get some assistance with your loan repayment. So it's sort of two different sides of the education approach, if you will, coming at it before versus after you've already completed it and you owe the money.
And I know that there are public health programs. I don't know the specifics that do engage students while they're in school, knowing that when they come out, they have to serve in underserved areas. Dr. Corman?
Yeah, sorry, I think I lost my connection there for a second. Yeah, no, I think the only thing I was gonna say with LARP is it doesn't necessarily have to be an underserved area that you're working in order to receive LARP. So you are getting on the back end, but it's not 100% the reason why you get approved for LARP. And I just think, like we were talking about before, the idea on the front end of doing it is, and I think we had talked about this before, like structuring it almost like the, armed services type scholarship programs where, they owe so many years of service afterwards. I mean, by giving them a tuition reduction, or even if it was as far that the state would approve free tuition with the idea that that person would owe, 4 years after in an underserved area. That was sort of the discussion I think we were having, is doing something big like that, that would actually really, I mean, if we're going to move people to those areas, I mean, this is something that would be a big driver of doing that.
If I may offer a friendly amendment to what is there, and that would be to provide funding to support tuition reduction, because in the absence of my concern is that if it's not funded, it's going to be difficult for institutions to support this. If it's simply, we want you to train and train for, for less. And so that would be my suggestion.
I agree 100%, Dr. Reynolds.
Thank you.
Thank you. So I think Dr. Doran, you had a comment now about.
Yeah, actually sticking with 4, could such funding come from a jurisdiction, say a county health department, say, hey, we're really underserved. Let's provide a grant to a dental student from our area to come back after dental school and work in our area is a possibility I throw out there. And then I had a question on, if we're done with 4, on 6.
That is possible, but state legislation is not going to get that funding.
Right, that would be up to the local jurisdiction. That's why I just throw it out that we may want to keep number 4 as Dr. Corman, Dr. Reynolds have edited here.
We could say the state and counties should, and if any county happens to see this report and think that's a good idea, they can take it upon themselves to do that as well.
It could be like a local jurisdiction as well. I know Hancock, Maryland reached out to us and say, hey, we have some vacant space in a strip mall and we need a dentist.
Okay, thank you.
If I could go on to 6, I do believe Dr. Romaine, the ADA has passed a resolution that they do support a national dental health benefit. So maybe we want to keep the struck out section on here and just keep your blue section.
I don't think I followed that. You want to keep this struck and then keep the new language?
No, on 6 where you've struck out in red, the American Dental Association does have a policy that we want to support vulnerable seniors through a Medicare benefit program. And then further, we can keep the part you have in the blue. So I think it's, yeah.
Want to see something like that?
Yes.
Okay, thank you. Are there any other recommendations?
I guess 7 got bumped up to 8 now. I do have a comment on.
Yeah, we'll fix all the numbering.
Okay.
Dr. Romaine has her hand up.
Oh,
So I was just going to go ahead with the last one, number 7, that's now number 8. So perhaps educate seniors on utilization of incurred medical expense to pay for their dental health care. So I guess now presently in the research I've done, there are about 2,000 seniors who live in long-term care across the state who have a dental insurance. It's called Health Drive, that pays for dental benefits while they're in long-term care facilities. And these are people on Medicaid, Medicare combined. So it's going to change a bit come January whenever they go on to Medicaid, but still these IMEs can be used to pay for dentures and some of the things that are not yet covered. So I think it's worth a mention here about the incurred medical expense and just educating. And really a lot of this, as I understand it, comes from whenever they are going into the facilities and working with the staff there to just kind of get their papers and insurances and everything in a row, that it's an option should they need dentures and things maybe not covered under the Medicaid program perhaps.
So this would be directed to staff in long-term care facilities? That they should be educating seniors?
Yeah, I mean, I guess in theory, you could be staying at home under the care of your family, not have a denture and be a dual eligible. I think, you know what I mean? It might be a smaller number. So it may involve more than just long-term care facilities. I would say I would leave that door open.
Well, I think the incurred medical expenses are limited to those that are residents in long-term care facilities. I don't think it can be used for someone who's at home.
Okay.
But that's, if I can get on my soapbox for a minute, I know we were assigned someone from long-term care facilities in our group. We've had no input at all, and I think we're directing this to directors of long-term care facilities and those administrators in Medicaid. Why is it so hard? Why are the administrators in long-term care facilities so resistant to use IMEs for dental care?
okay. So does this recommendation satisfy what you're thinking about?
And relatedly, is there some more background information that you'd like to give on the basis for why this is an issue, why this is a barrier that needs to be addressed?
Yes, I can get you some more background on that. And I also think we need to somehow increase the knowledge in these long-term care facilities that this is a benefit for those Medicaid patients that are residents of theirs. I don't see them, they somehow seem reluctant to use this when they call me when someone's lost a denture, for example. And yet they'll use it for eyeglasses, hearing aids, walkers.
Okay. Well, we have 7 minutes left and we have 3 subgroups to review. So I'd like Lindsay to give us our options for the next meeting, because I don't think we can start a new group now.
Okay. So just broadly looking into the future, the next full meeting of this task force is for October 20th. And at that meeting, we intended to be voting on the final draft of this report, which we hoped to circulate to everyone by October 6th to give everyone lots of time to review that final draft and make sure that everything is correct. So that said, we've got before then, if we stick to the Thursday dates, September 22nd and September 29th as potential meeting dates to finish up working on this report. and the time slots, we could stick with 10 to noon or look at the 4 to 6 meeting date. The October 20th meeting is supposed to be 4 to 6 p.m.
So would you, can you?
I think there's
send
been a
out-
lot of good progress today, so we probably won't need a full 2 hours for the next meeting.
I agree, a lot of progress, and thank you all for the discussion. Can you send out a poll so that we can determine what the next meeting will be? Is
Sure.
that possible? Okay, with those options.
And what I'm going to do, hopefully everybody is available to respond quickly, because if we are looking at meeting potentially next Thursday, I think it's important that we get that on everybody's calendar as quickly as possible. So I'm going to ask everybody to hopefully respond by the end of the day tomorrow.
Great.
For the October 20th meeting, if it's not going to be a full 2 hours, could it start at 5 instead of 4, since schedules would not have to be broken up? Is that an option? Just asking.
That's fine with me. I can't speak for everybody else. We could include that in the poll if you'd like.
Yeah, why don't we include that in the poll?
Okay.
Thank you.
And just to clarify, the October meeting is really expected to be pretty short. The next step would be to vote on this final report, which would be pretty straightforward, and then just discuss the next steps in general for the task force.
So are there other meetings before the October 20th meeting, or?
Well, that's what we're talking about. We're talking about
Okay.
a meeting either the 22nd or the 29th. I'll send out a poll. So that would be either 1 week from today or 2 weeks from today to finish discussing this draft report. And I'll also, I guess there will be 4 options, because we'll look at 10 a.m. either of those days or 4 p.m. either of those days.
And we don't expect it to be as long, because we've gotten through the lion's share of it.
Yes.
Okay, great. Dean Reynolds, do you
I
have?
know this. Thank you, Dr. Hughes, for taking the lead. And I'd like to thank our colleagues and Delegate Bagnall.
Yes, is Delegate Bagnall still on the call? I can't see.
Yes.
I'm still here.
Okay, would you like to say anything?
I'm actually in a really loud place, but I just wanted to thank everyone again for your commitment of really doing this work and thinking strategically and really digging down into this issue. So thank you.
Thank you so much. And I'd just like to take the opportunity to thank Lindsay and Tyler and Ellen for their work on this report. It's been amazing. And you've made our jobs much easier. Thank you so much.
Thank you.
Really appreciate it. All righty. Have a good afternoon. We're done for today.